Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. Chuck Peck is a Managing Director at Navigant Healthcare. He is an internist and rheumatologist with more than 35 years of healthcare experience as a clinician, scientist, medical school faculty member, administrator, medical director, CEO and partner in a global healthcare advisory company. His areas of expertise include health, strategy, and policy, performance improvement, clinical and operational excellence, change enablement, clinical care, leadership training, quality and utilization management, and risk management for hospitals, health systems, and physician organizations. As a managing director, he co-leads the firm's healthcare performance improvement practice and directs the clinical and operational excellence service line. And running late, but hopefully we also will have Dr. Thomas K. Miller, who practices at Orthopedic Sports Medicine and General Orthopedic Surgery at Carilion Clinic Orthopedics in Roanoke, Virginia. With 30 years of clinical experience, Dr. Miller is also an assistant professor at Virginia College of Osteopathic Medicine, a clinical associate professor of orthopedic surgery, and instructional faculty at University of Virginia, as well as an associate professor in the Department of Surgery at Virginia Tech Carilion School of Medicine. In addition to his teaching work, Dr. Miller has presented at many notable conferences and has also served on a number of panels, including the CMS Technical Expert Panel, HOSD/ASC Experience of Care Survey, 2012 and 13, and the Virginia Orthopedic Society Board of Governors in 2012. It is now my pleasure to turn the floor over to Dr. Peck to begin today's presentation.
Thank you. Thanks everyone for attending. One other point relative to my introduction. You're probably wondering also what a rheumatologist and internist is doing presenting about infections in ASCs. And you know, I'm the recent CEO of a national ASC company as well, and so we've dealt with these issues for a long period of time, as well as being on the board of the Ambulatory Surgery Center Association, where this is a very high priority topic because of some of the things that CMS is looking at, which we'll talk about during the presentation. The only other thing I'd like to say before starting the slides is that I recognize that some of the slides will be extremely
muted.
However, there are many slides that are also directed towards folks who aren't necessarily doing this work on a regular basis. So while some of this may be obvious to some of you, we still have significant issues related to infectious problems in our centers. And I'm sure some of you are aware of the issues as they've appeared on the front pages of some newspapers, et cetera. So this is a really important topic. And I just want to start by saying that it has the highest priority at CMS, Medicare, and they're going to be looking more and more carefully at this. And so we felt this was an important topic to cover. So thank you for that. Can we go to the next slide? Next slide. Thank you. So the quote I just wanted to start with from HHS in 2009 is that the overall burden of hospital-acquired infections in outpatient settings is unknown. However, it is evident from the infections that have been identified that it's a significant problem resulting from very basic infection control failures. I think one of the things that I know we talk about at the Ambulatory Surgery Center Association is the difficulty sometimes we have with folks in government, whether they be at CMS or the CDC. A lot of those folks assume that whatever goes on the inpatient side and in hospitals also must be going on the outpatient side. And we spend a lot of our time talking to those folks, as well as some of the people who actually write legislation about the differences. So I just want to put out there that we shouldn't assume that the same problems occurring on the inpatient side are the same problems in the outpatient arena. I recognize that. I know you all recognize that. But some of the legislation and things we'll talk about today, you need to assume that a lot of the folks who are writing these laws around the things that control us in our ambulatory surgery centers are really a reflection of reaction to some of the newspaper articles and the 1 in a million complications and things that happen to a patient in an outpatient setting. So I think we all need to be cognizant of that, because it'll help inform us as to the way we work with these legislators who are pushing the laws down on us in terms of what we need to do. Next slide. Thank you. So the 4 major objectives of today, really the foundation of what we're trying to do is to, at the end of the day, improve the quality of patient care and the cost effectiveness. In other words, increase the value that we're able to provide to patients in our ambulatory surgery centers. So we wanted to talk about infection prevention protocols and how they can help us demonstrate quality of care, and why reporting through several of the quality initiatives that are out there is really important for us, because of what I just said about the folks writing legislation, etc., as well as just providing good care. We want to review current infection prevention guidelines. We want to talk about how to design and implement an infection prevention protocol. This goes a lot to, I guess, the evidence, the same thing as when we talk about evidence-based medicine. And it also goes to some of the safe harbors that are being suggested, whereby physicians who follow guidelines can be within a safe harbor when it comes to malpractice and other litigation. So I think that's an important piece of what we want to do. And then finally, understand how to engage our staff to promote compliance with the guidelines and the protocols at each of your facilities. Next slide.
Chuck?
Yes.
This is TK. They finally got the rest of the audio stuff taken care of online.
Okay.
So.
Okay, go ahead, TK. Certainly,
thank you. So I'll continue for the next few slides. The healthcare-associated infection, you'll notice that HAI used to refer to hospital-associated infection. Certainly moved beyond that, as a much larger number and volume than people originally felt. As the slide shows, 1.7 million people acquire healthcare-associated infections per year. The number of 271 deaths per day. Typically, folks think of that as hospital-based, but in fact, it's not hospital-based alone. More importantly, 1/3 of these healthcare-associated infections are preventable, and I think that's the biggest issue. Is there are a number of areas where these are problems that are straightforward and can be handled up front to avoid them down the line. Next slide, please. When you look at absolute numbers, there are over 5,000 outpatient or ambulatory surgery centers in the United States. Over 6 million surgeries are performed annually. In our community, there are far more outpatient-based and ASC-based surgeries than hospital-based at this point. And that number is shown as more than 3/4 of all operations in the U.S. are actually being performed on an outpatient basis. Those numbers continue to increase, and what we've seen is the health status of patients has shifted, where traditionally the thought was that most ambulatory care was going to be on relatively healthy, relatively young patients, and I think anybody that looks at it at this point will see that these are older patients with a higher number of comorbidities than we used to see in the past, and the complexity of the procedures have certainly increased. So the previous thought that this was something that somehow ASCs lived in a safer zone is no longer the case, and really we have to have standards that at minimum meet those of hospital-based surgery, and if we're going to present ourselves as the best alternative, should in fact exceed them. Now, the one thing that has come up repeatedly and has been reported are an increase in healthcare-associated infections in outpatient settings, which are attributed to unsafe medical practices. And there are a number of articles, and there have been a number of reported outbreaks of communicable disease, not just breaks in sterile technique, but communicable disease based on poor practices that were the basis for a number of the changes by CMS and other regulatory bodies. Next slide, and then back to Chuck, please. So the question of why should ASC go? I'm sorry. So why should ASC? Yes. So why should ASCs standardize infection protocols? Well, probably the most telling one was a 2010 CDC report where they allowed ambulatory centers to voluntarily participate in a pilot study to show what their infection control practices were. What was somewhat alarming from that is that these were self-selected centers putting themselves out as models where significant lapses in infection control were found to be common and could potentially place patients at risk. The thought was that standardization could help eliminate some of the variability that occurs in processes, implement evidence-based products that could result in less waste, more importantly, fewer errors, better quality outcomes for patients, the net result being increased cost effectiveness, and then the last, which was a fairly common finding, were medication or medication dispensation errors and healthcare-associated infections. Next slide, please. Chuck, you want to go ahead?
Sure. So as many of you are aware, again, there are CDC guidelines that outline what the effective approach to infection control is. And again, some of these are obvious, but unfortunately, they're still not occurring in all outpatient settings. So patients, need to take an antiseptic shower or bath the day before the procedure, and they need to be told this and repeatedly to make sure that they do this. If hair removal is deemed necessary, it should be clipped immediately before the surgery. The skin at the site of incision should be prepared with an antiseptic, and it should be through the use of preferred agents that provide rapid, persistent, and broad-spectrum antimicrobial activity. The surgical team of personnel, all of them should wash their arms and forearms with an antiseptic solution before putting on gloves and gowns. So, and again, these are the obvious things that are certainly done on the inpatient side and need to be done on the outpatient side, obviously, as well. The organization, and this one's important, must implement policies to prevent transmission from personnel to patients, and the policies need to be written down. And antimicrobial prophylaxis should be administered before the operation begins, typically via intravenous infusion. And generally speaking, I think it's fair to say that most all the skip measures that we utilize, generally speaking, for surgery should be utilized for surgery on the outpatient side as well. Next. There are administrative recommendations as well as clinical recommendations. The recommendation is to develop and maintain an infection prevention and occupational programs within the center or centers, assure sufficient and appropriate supplies necessary for adherence to all of the precautions, make sure that there's at least one individual in infection prevention regularly available to the facility. I just want to point out that this is, I think, a very effective approach to this has been in multi-facility organizations is to have at least one or several people trained and certified in infection prevention from the clinical staff, and then utilize those people on a regular basis to be in the centers or speak with the centers and sort of be the designated director of infection prevention. And that goes a long way towards assuaging the concerns of payers and Medicare. And then written policies need to be developed and procedures appropriate for the services provided that are based on evidence-based guidelines and regulations. Next slide.
And in 2009, CMS began enforcing new conditions for coverage for ASCs that required adherence to several revised infection control practices. And these come back to a number of the points that were presented on that previous slide. Now, the two issues from that slide that are probably the most important are the designation of one individual or a team of individuals who are responsible for infection control, and then establishment of specific written policies and procedures. And those are an absolute necessity, and once those are in place, they sort of start the cascade of the best means of preventing infections in a facility and how to monitor that long term and address issues should they arise. Next slide, please. So what we're talking about is a written program as the best way to handle this. Just saying that we monitor or we have policies in place, they're only as good as the written policy, and I will say that sitting down and reviewing what's available and establishing a policy for a center is unquestionably the best way to get everybody on board, and then to repeatedly bring this up as part of educational maintenance for staff. Some of these may seem straightforward, but certainly in the reviews that were done, some of the points presented here are ones that oftentimes fell through the cracks. You would think that maintenance of a sanitary environment would be straightforward, but that comes down to, in fact, how do you care for your facility, who cleans the facility, what are your policies on cycle cleaning, and they should be well-defined and continued on a regular basis. There have to be development and implementation of infection control measures related to personnel, and that includes maintenance of inoculation, TB testing, and other test or immunizations that all staff should be up to date on. There are areas where risk can be mitigated associated with patient infections upon admission. One of the ways to address this is certainly for non-hospital-based ambulatory centers, a policy that no patients with an ongoing or recognized active infection can be done in a facility. Simply reducing the at-risk load to the facility does make a difference. Same thing goes to the point of mitigating risk that can contribute to hospital or healthcare associated infections. There does have to be an active surveillance program. That means monitoring feedback from staff and physicians and a regular update on those areas to make sure that policies are being adhered to, and when issues come up, that there is a means of addressing concerns when they can come up and backtracking to see if this is a random occurrence or something that is becoming a consistent or repeatable problem. Monitoring does have to be in compliance with all policies, procedures, and protocols. And an area of commonly reported problem is an administration of drugs when you look at either single-use vials or multi-use vials. The problems that occurred at a center previously had to do with repeated use of the same needle and same syringe for multiple patients. Another study was based on something as simple as glucose monitoring lancets that were used repeatedly and were not cleaned between patients. And you would think those are common sense, but those are areas that have been seen, and the policies need to be very straightforward. And there are sources to retrieve those. You have to have a means of evaluating follow up on your infection control policies, revise them when indicated. They're not carved in stone, and actually as things evolve, there does have to be a policy to update that and bring everybody on board. And then there's certain policies that are mandated by compliance with either federal, state, or local policies, both referable to emergency preparedness and communicable disease policies. Next slide, please. So there has to be a designated, qualified, licensed professional to lead the infection control program. That means selecting someone, preferably someone to back them up if they're not around, making sure that they've gone through an appropriate and approved training policy and that they maintain their competence at that level. So there needs to be a specific job description. Certification is not required unless it's specified by state laws. However, the better you do at showing that your infection control officer has the best possible training and certification, the better you do if there are ever discussions about problems that occur. And it's just an issue that this is the best way to handle things. There does have to be documentation that this person has training that qualifies them to lead an infection control program, such as ongoing education, training and courses, participation in local or national meetings. And these are certainly accessible both by direct meeting or online to make sure that you're maintaining your infection control officer at the level of education that they need to be. Some questions to consider in the ASC is there documentation of that training? The answer is you need to keep that. And do you have a means of documenting how much time they spend on it? To just simply say, we have someone and they've gone to X, Y, or Z course, this really gets down to a much more consistent and regulated means of documenting that you have these policies and personnel in place. Next slide, please. So the biggest problem about ASCs, there is a risk of inconsistencies. There are a number of areas of pressure in ASCs, whether or not it's the length of case, the number of patients that come through a facility, the length of turnover time, the number of FTEs employed at a center. These oftentimes are areas where there's pressure to move quickly, and there's a risk for habits to develop that are not in the best interest of patients. You oftentimes have many different providers working at a facility, and although it's easier at a single or limited specialty facility, even those have their issues. But once you move into facilities that have many subspecialties, it becomes much harder to keep track of their subspecialty or procedure-related risks referable to infection. And it's just that you have to do it. The more specialties you have, the harder it is to keep track of it, but it doesn't lower the bar on what you're permitted to do. And certainly certain specialties have different habits or methods. It is not uncommon to see, I hate to use the word, but a drift from one specialty to another. One of the comments often made is, if you have a facility that has ENT and orthopedics in the same facility, one room, the question is, why does anybody wear a mask and everybody should scrub when they leave, as opposed to the opposite in the orthopedic room. But the reality is the management of infection control should not really be specialty dependent. It ought to be a bar that's set high for everyone. Surveillance outcomes for ASCs are challenging because the patient encounters are brief or sporadic, and that it's a very, very high volume. And evaluation and treatment of consequent infections may be involving different healthcare systems. One of the ways around that is mandatory feedback and review of every patient in a facility for complications and infections in the postoperative time frame, both by monitoring facilities or by direct reporting by the physicians involved. And one of the ways to handle that is that to maintain privileges at a facility, the physician providers must participate in the feedback program and record every patient that they've had through their facility referable to any post-op complications or infections. Next slide, please. So if you look at this, we're really talking about areas that have to link into each other. You have to identify best practice. You have to look at what that requires for process and behavior. You do have to have a plan that allows it to be implemented. A draconian plan usually gets nowhere. Staff and providers understanding the rationale, and sometimes it does have to be, this is a rule and that's all there is to it, but more importantly, this is how we maintain a level of quality and this is how we maintain a level of patient safety, goes a long way. It always requires training, and that always does require updating. There's no way around that. And then the end results are that you have to be able to look back and say, yes, we've maintained a level of patient safety, or if issues occur, we have a means of looking into that and making sure that it does not occur again in the future. Next slide, please. So there are 4 points that we think about to establish standardization of infection control programs in ASCs. One of them that's not often thought about is you do have to understand the culture of the community. And a previous point had to do with the pre-op showers. Certainly, it's something that at our hospitals we can really push based on pre-op teaching for, and I'm going to use the example of total joint patients. It is more difficult to implement in an ambulatory setting. There are alternatives to that, including site-specific HYGIENE scrubs or chlorhexidine scrubs prior to surgical procedures, which is an alternative. You do have to know what's going on in your community, and you do have to know where your patients are coming from. We, in our area, as a number of areas, dealt with outbreaks of community-acquired MRSA in athletic populations. That required a look at how are we going to handle these patients when they come in, because they're already deemed as an at-risk population. So while we have policies in place that we use as a routine, knowing what's going on in the community allows you to make adjustments to address problems head on. The second is understanding the culture of the ASC itself. The ASC really has to have a culture of patient safety and prevention of infection. You do have to comply with the regulatory guidelines and policies, and then you absolutely have to be able to monitor your results and track infections when they occur. Next slide, please. So again, we've discussed this, understanding the culture of your community. Certainly to survey and know your community, you have to know if you're dealing with high-risk patient populations, and if necessary, take extra precautions with those patients. Next slide, please. And then in the ASC itself, there has to be a culture of infection prevention. One of the things that I encountered when I first began practice was the common perception of it's just an outpatient procedure, as if somehow outpatient procedures or procedures done in an ambulatory setting did not require the level of concern about infection that a hospital-based. I think the change has been, and patients' perceptions are, that ASCs perhaps are a safer place for a number of procedures, certainly a lower incidence of infection, and it's our job to maintain that as our standard. There are some simple things, excluding infected wounds as a policy for a facility if you have the capacity to do that. Hand cleaning stations only work as well as access to the stations. They have to be almost thoughtless, that if you enter a room, if you leave a room, if you come near a patient, if you leave a patient, there has to be a means of cleaning your hands. Cleaning the rooms themselves have to be up to appropriate standards. We have a policy to reduce the number of people entering the surgery areas. People don't question on a total joint room that there's a sign that says you should not enter this room. If you need to speak to someone in this room, either come through the substerile area with a mask or call the room. we owe our patients the same things in ambulatory settings, and people repeatedly coming in and out of a room to ask questions or to find out about the next case is not the way to handle things. Next slide, please. Chuck, if you want to go ahead.
Sure. So let's just talk a minute about employee health in the ASC, and I'm going to be looking at some areas that involve, clinical standards, et cetera. And I want to, over the next few slides, spend a little bit more time talking about the safe use of single-dose and single-use medications, because if you don't get anything out of this webinar, I want to make sure that you understand that this is where the government and CMS has their microscope out. So we'll talk a couple of extra minutes about that. But let's talk about infection prevention and how that starts really with the staff in the center. Maintaining the current protocols pertaining to all communicable diseases, including things like flu outbreaks and employee immunizations, as well as employee time off for sick time and the procedures and protocols for that. Very important. Following the current state-specific and CDC guidelines for tuberculosis, again, very important. If the employee job functions change, performing another risk assessment. And again, all of the things that we're talking about need to be documented, and documentation is probably the best way to mitigate any risk when a state, local, or government, federal government person shows up to do an inspection of your center. Revisiting exposure control plans annually, ensuring that the policies and procedures pertaining to exposure incidents are reflective of current practice and best practice. And again, record keeping is just, it's an absolute must. If it's not documented and written down, then assume that nobody will believe that it happened. That's probably the safest policy. Next slide. Complying with the regulatory guidelines and policies that are out there. Important areas for ongoing regular assessment include the basic elements of infection prevention, whether it's hand hygiene or antisepsis that we talked about, the use of nails, jewelry, and gloves. We'll get into that in a minute a little bit more. Skin antisepsis that we've already talked about, and injections, infusions, and medications, which I'll spend a minute on. Looking at the role of the environment and just the whole process of cleaning, disinfection, and sterilization. And again, I think that this may be self-evident and obvious, but when somebody walks into the facility, they tend to, I think, give people the benefit of the doubt with what's going on there if at least they start off when they first walk in seeing what appears to be a clean, disinfected, and sterile appearing environment. I think the opposite occurs if they walk in and the physical appearance of the facility is not clean. And so again, the optics that you put around what you do relative to cleanliness, sterilization, et cetera, is very important for the general impression that you leave on people, particularly the surveyors. Next. So again, some of the regulatory guideline and policy talk. CMS has provided an example of an audit tool that's being used by surveyors to assess adherence to the elements of standard precaution. I would strongly encourage you to go to the CMS website. Just type in ASC. There's a lot of really great information so that you can be proactive about this rather than reactive or end up being cited and having a significant number of issues, which is very difficult if for those of you who have never had that happen. Those of you who have know what I'm talking about. The tool, asks several things, but mostly focuses around guidelines for isolation precautions, hand hygiene, environmental infection control, peri-op standards, etc. So again, I would strongly encourage you to go to the link on the CMS website if you haven't been there already. Next slide. So in terms of hand hygiene and surgical hand antisepsis, the CDC and CMS both really focus on this because they consider it to be the first lines of defense. I'm giving you what the FDA and their definitions of hand hygiene are. They consider it a general term. It applies to either hand washing, antiseptic hand wash, antiseptic hand rub, or surgical hand antisepsis. And the staff need to clearly understand when and how to perform hand hygiene. And as TK said, the hand hygiene units or wherever it is that they're performing this need to be easily accessible and obvious and in their face. And you need to conduct random checks to make sure that they're doing what they need to do to ensure quality. In terms of surgical hand antisepsis, the government and others define this as the pre-op use of an antiseptic hand wash that requires water or an antiseptic hand rub that doesn't by surgical personnel to eliminate transient and reduce resident hand flora. And the products must meet the FDA requirements. So I would encourage you to make sure that whatever product you're using, that it does meet all the FDA requirements, which again you can find on the site, including that it has to be persistent and cumulative in the bacterial log reduction on the skin over time. And again, there's an example down at the bottom of the slide of 11 washes over a 5-day period and how things are tracked and logged. If you look at the monographs in the FDA, you can get a very good sense of exactly what people are going to be looking at if they come into the facility in terms of what you've recorded, et cetera. Next slide.
Chuck, on that last slide, it's interesting when you look at the picture of the hand hygiene device. This may sound like something that's simple, but it's surprising when you go in and look at facilities where and how these are mounted. It is not uncommon because somebody feels they have to be in place. They're mounted in a position that makes it next to impossible to use them effectively. So and we run into this on a regular basis that, yes, we spent the money and we've put them into place, but only 3 of the X number in a facility are actually usable. And it may seem like common sense, but you need to remember that the people that are installing them are not the people that are trying to use them and maintaining compliance. So it does, in fact, require feedback from start to finish on installation to use. And we've seen this on a number of occasions that, put one here, here, and here, and you come back and maintenance has done a very nice job of installing them in a place that forces you to contaminate your hands every time you use them.
Yeah, good point, TK. Again, just to make the point that the CDC, CMS, the FDA, the WHO prefer the use of alcohol-based hand rubs as the primary mode of hand hygiene. And when you compare that with soap and water, it can increase compliance with the recommendations for hand hygiene practices by requiring less time and irritating the hands less. So we're strongly recommending that you look at your hand hygiene products and take this recommendation into consideration. Next slide. Nails, jewelry, and gloves, also really important. Artificial nails and extenders are more likely to harbor gram-negative bacteria on the fingertips. You probably ought to think seriously about disallowing that amongst your staff if it's at all possible. Acrylic base facilitates microbial adhesion. You should not, nor should any of your staff, wear artificial nails or extenders when they have contact with a high-risk patient. And epidemiologically implicated, they've been epidemiologically implicated in various types of outbreaks. So I would have an educational session with any of your staff, and I would strongly encourage you to not allow them to utilize artificial nails. Skin underneath rings tends to be a lot more heavily colonized than other areas. If you look at some recent studies from ICU nurses, rings were the only substantial risk factor for carriage of gram-negative bacteria. Something else that I don't think a lot of people realize. And, again, it's obvious, but all of us that utilize gloves should remove our gloves and immediately perform hand hygiene before moving to the next task or patient, and wear gloves when handling potentially contaminated equipment. Next slide. So again, pre-op skin antisepsis is key here. And 11 leading organizations recommend that skin antisepsis be done with 2% chlorhexidine gluconate solution. And that solution, you know, a 2% solution mixed with 70% isopropyl alcohol is rapid acting, persistent, it works on a broad spectrum of bacteria. So again, if you're unsure whether or not the solution that you're using meets this criterion, I would recommend that you look at that carefully next time you're in the center. It's consistent with CDC guidelines in terms of a skin prep should be applied with an applicator to eliminate direct hand-to-patient contact. It's sort of similar to what TK just talked about, whereby if you do something and then are forced to be in a position where you break the sterility or cleanliness, it really didn't do you any good to do it in the first place. Additionally, a hands-free application with an applicator helps prevent cross-contamination. Next point. Thanks. Let me just diverge for a second here and talk about medication vial practices, because what I'd like to do is please encourage you, again, to go onto the CMS website. This is probably the most active area that CMS is looking into right now relative to your centers. And there's a memorandum on the website from June 15, 2012 that I would strongly encourage you to read. And let me just read a couple of things from the memorandum. And this has to do with the safe use of single-dose or single-use medications. And there's a lot of misunderstanding and miscommunication going on, so I want to make sure that you're all very clear about what is and isn't allowed. Under certain conditions, it's permissible to repackage single-dose vials or single-use vials into smaller doses, each intended for a single patient. So it's not that this is being prohibited completely. It's that there are only certain things that are approved and allowable if you're going to do this. And so let me continue. You'll see that this whole policy falls under something called the USP 797, which is part of the code. Healthcare facilities may repackage single-dose vials into smaller doses, each intended for use with one patient. Among other things, the standard currently requires that the facility doing the repackaging must use qualified, trained personnel to do so. All entries into a single-dose vial for purposes of repackaging under these conditions must be completed within 6 hours of the initial needle puncture. The second thing is all repackaged doses prepared under these conditions must be assigned and labeled with a beyond use state called BUD, based on an appropriate determination of contamination risk level in accordance with USP 797. And then the last thing I'll mention is the deficiency citation policy associated with this. Healthcare facilities that do not adhere to USP 797 standards but reuse single-dose vials for multiple patients must be cited for deficiencies under the applicable infection control standards. On the other hand, healthcare facilities that utilize appropriately stored medications derived from repackaged single-dose vials and prepared in accordance with USP 797 must be cited solely on the basis of this practice. So what the government, CMS, is saying is that it's not that we're prohibiting this completely, but if you're going to do this, you have to do it under the strictest of conditions, and if you don't follow those conditions, we're going to cite you every time. And I can almost guarantee you that the first thing that any auditor or inspector is going to look at when they come into your facility over the next 6 months, in a surprise fashion or otherwise, is your use of single-dose medication vials. So I can't emphasize enough how important it is for you to look at this memo and look at your use of this, because this will be the most common reason for you to be cited for the foreseeable future. So when we look at safe injection practices, and going back to the slide, we want to reduce variability to improve infection rates. And how do we do that? In terms of injections, you obviously disinfect or scrub all the vial tops, the IV hubs and ports, etc. for 3 seconds. You use one sterile needle, one sterile syringe for each injection and each entry into a vial. For infusions, you want to begin administration within 1 hour of spiking the IV bag, and that's also within the regulation that I just referred to. And it's best if the irrigation solutions are discarded between patients. And then in terms of medications, never leave a needle inserted into the medication vial. Septum for multiple uses. Use a blunt needle to withdraw the medication. Single-dose vials, as we talked about, like propofol, should never be used for more than one patient. It's recommended open multi-dose vials are discarded at 28 days. Discard prepared syringes at the end of the case. Don't save it or even take the chance that it could possibly be used on the next patient. Administer all eye and ear ointments with a no-touch technique. And if the tip of the container does touch the patient, get rid of it. Obtain topicals in the smallest possible unit that you possibly can. And all pre-drawn syringes have to include labeling. Next slide.
Hey, Chuck, can I make a couple points about the slide?
Of course.
If I just go back for,
yep.
Because this is an area where oftentimes, and this is not to step on specialty toes, but this is an oftentimes an anesthesia-based issue. If you're in a facility that's doing a large number of procedures, particularly a facility that does regional blocks or pain management, this question comes up all the time. And the only way to address this is exactly as shown here. It's a one setup, one set of medications appropriately labeled per patient. This is an area where you may have to just sit down and say, we're going to sacrifice so-called efficiency for patient safety. And we deal with this all the time, and we have a no-tolerance policy that it is single draws, medication set up, labeled for a specific patient. You don't get to set your stuff up for the day for specifically the reasons that Dr. Peck just said, is that you don't want to risk that. The one other area, if we come back to infusions for irrigation solution, if you have a facility that does a large volume of arthroscopy, you need to know the specific system being used. There are actually closed chambered systems that close off irrigation that you only exchange tubing on one side, but you absolutely have to know which system you're using. The majority of them on the market do not have that, and all the irrigation solution has to be discarded from patient to patient as opposed just to the tubing on one side of a pump. So that's the one area that is very much equipment specific, and your staff has to be aware of it. We have staff that work at 2 different facilities, and one facility uses one type of pump and the other facility uses a different pump, and they absolutely have to be aware of that because of the potential risk to patients on that.
Thanks, PK. Next slide. So looking at the role of the environment, we just wanted to give you an example of a survey form that you could utilize. Our observations are to be made of staff who perform environmental cleaning. This is specifically for the people who are cleaning your facility and the operating rooms. And so here's an example for you of some of the things that you need to be auditing and documenting. I'm not going to go through this, but we've provided this for you. Next slide. Looking at the environment of care assessment, there are certain things that you ought to be doing on a regular basis, like spot checking external services for housekeeping, looking at positive versus negative air pressure gradients, obviously measuring your humidity and temp levels, and these are all, as you know, on the survey. There's a list of things to look at, looking at your air changes per hour, any potential privacy or security risks or ergonomic hazards, handling of chemicals or hazardous waste, etc. I'm sure you're all doing this. Again, we just wanted to give you the list to make sure that you were auditing all of the things you needed to be. Next.
Okay, so as far as cleaning, cleaning, disinfection, and sterilization, you always have to perform instrument decontam prior to sterilization or disinfection to remove the bioburden and foreign material. Certainly for lumened equipment, this is an issue. One place to consider ultrasonic assistance is if you have a practice profile with a large volume of lumen instruments that are going to be used again. You should at least consider that. It's expensive, but it's something to be considered. But you have to have a policy in place that everybody understands that every lumen piece of equipment gets looked at and cleaned appropriately. So it's detergent and water, enzyme cleaner and water, ultrasonics if necessary. Items coming in contact with non-intact skin or mucous membranes are considered semi-critical and should receive high-level disinfections at a minimum. You really need to look at what's the best way to clean and prepare certain items that are going to be used over again. You have to use an FDA-approved chemical agent. There has to be a minimum effective concentration, and you need to record that you're maintaining that. It has to be checked prior to each use. It does require specified contact conditions, which include concentration, length of time, temperature, total immersion, channels, again, getting back to the lumen materials. And otherwise, you're basically reusing equipment that can contaminate the next patient. Coming back again, effective sterilization cannot occur without effective cleaning. You really need to keep flash sterilization to a minimum. A policy should be that you maintain minimal number of flash sterilizations, and this is an area where, based upon the practice profile of a facility, purchasing additional equipment to reduce the incidence of flash sterilization has to be strongly considered. It's an upfront expense for patient safety, but quite frankly, it's an upfront expense that significantly improves efficiency. A number of places that we've looked at who were resistant to this have found that by purchasing adequate amounts of equipment for the procedures they expect through the course of a day allowed them to improve their efficiency, and so it was a win-win situation. Sterilized items should be labeled with sterilization date, sterilizer, and load numbers. Again, this is a tracking issue. You really need to be able to track everything from something as simple as sutures to obviously every one of your implants, but also how your packs are sterilized. If you run into a sequence of issues, you need to be able to go back and see, again, is this a consistent problem, and if so, how did it occur and how do we fix it? Sterile products have to be stored under environmentally controlled conditions. Temperature should not exceed 75 degrees Fahrenheit or 70% humidity. Air exchanges are as listed. You do need to keep them off the floor and away from the sprinkler heads. Don't use cardboard. Rotate your supplies so you don't have things sitting somehow hidden in the back that are like the carton of milk that finally comes to the service out front of the refrigerator outdated. And you may not think, but you have to look at actually the racks and trays of how your equipment is stored. And the issue of could you have potential penetration of the packaging wrap for sterility based on simply how you slide them in and out or where you store them on your racks. Next slide, please. So tracking results is critical to demonstrate effectiveness. CMS requires 4 weeks of tracking for infections. Actually, probably a more reasonable tracking is 6 weeks, which is what we require, and that's the feedback basis that we use. I think it is more representative. So going over doesn't hurt anything. Perioperative, quote, complications are typically listed as 6 weeks rather than 4. You do have to track all product lot numbers. Large ones are ones that people think about without too much issue, but you also have to think about smaller products, including sutures. You do need to review all your procedures each quarter. We ask our surgeons to track each of their patients. We send them a list at the end of each 6 weeks. They are to report any conditions, which takes care of some of the issue of a problem that presents later and comes into a different facility. And on occasion, you may need to consider tracking your nurses or teams to see if there is a component based on personnel or personnel practices as opposed to implants or the center itself. Next slide, please. So really, when you look at this, like any Venn diagram, at some point everything overlaps. But the bottom line on this is that nothing occurs in a vacuum. You do have to be able to look at your patients, think about how your facility works, look at your physician contribution, and actually the other large component is really your staff at your facility. And you can control parts of these. And the ones you can control are your facilities, your staff, your physicians. You can control how you manage your equipment, and you have to adapt to your patients as best you can for their own safety. And I think that pretty much gets us into summary slides now, correct? So the must-haves. There has to be an ongoing program to prevent, identify, and manage infections in accordance with nationally recognized infection control guidelines, and these are readily accessible, and it is something that you need to look at. Ensure that the program is under the direction of a designated, qualified, licensed healthcare professional with appropriate training and maintenance of training. There does have to be a functional and satisfactory environment, sanitary environment for provision of surgical services, and there do need to be tracking mechanisms to immediately correct actions. You have to be able to recognize them, you have to be able to go back to the root cause, and then you have to be able to take corrective action if issues occur. And that's pretty much it. Next slide, please. So case study, Lakeland Surgical and Diagnostic Center's ASC-SPECIFIC Infection Control Program. This was provided by Becker's ASC Review. So this was back in 2007. Dave Daniel decided that facility needed an infection control committee. A specific individual was appointed. They reported their infection rate out of their 19,000 cases. How did they manage this? Mandatory staff meetings. Quarterly, the staff from the organizations meet, discuss infection control topics. And it's a broad spectrum, and it allows everyone to stay up to date. Physician involvement. So they went right to the front end and got 2 physicians, an epidemiologist and a pathologist, to sit on the infection control committee. It's always hard to get people involved, but it's much easier to get them involved, or it's better to get them involved before issues occur than try to dig yourself out of a hole later. They have instituted an abbreviated environmental surveillance each month, and then in-depth surveillance done quarterly. Facilities that I'm associated with review infection control at the Medical Advisory Committee each quarter, and that is reported to the facilities board so that everybody knows what's going on. And the goal is to find deficiencies or patterns ahead of time and provide incentive to follow proper procedures. And then, again, having an administrative champion instrumental to develop the infection control program. Thank you.
Okay, well, thank you, Dr. Peck and Dr. Miller, for your very informative presentation. We have just a few minutes for some questions, and as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the few minutes we have left, and we'll follow up on any questions they don't have the opportunity to address. One question we have, are there any strategies or methodologies for training staff?
I can tell you how our facilities do this. Our infection control officer is responsible for knowing what current standards are, and at least one of our staff meetings per quarter, preferably 2 staff meetings per quarter, if there are changes in regulations or if we have seen any issues occur, are reviewed at mandatory staff meetings to bring everybody up to speed. Those are recorded, and each staff member is required to either be present or review the recording and the information that goes with it as a component of their employment.
Okay, thank you. There's a lot of talk about pre-op showers. how do they fit into a standardized approach, and how do you ensure patients do it?
I will probably step on some toes about this one. Total joint patients, because of the education sessions that we have, and these are hospital-based patients, are an easier population to instruct in that. It is much more difficult in an ambulatory setting to get patients to buy into that. It is not without its own issues. Chlorhexidine is of concern for mucosal membranes. I will be the first to say we have a patient population that is not always going to go out and pick up chlorhexidine. There are two ways around that, but the one that we found the best is to assume that patients won't, even if given direction, and do an on-site scrub the day of surgery. So they basically get their site-specific chlorhexidine scrub in the facility before they go back to the OR for their prep.
Okay, great. Thank you. Do you have any tips on improving compliance of surgical hand scrubbing?
Besides the nurse that's been there for 40 years that stands out and stares at you, which is how I trained. I think one of the issues is with the newer agents, compliance is much better. You know, we have the first scrub of the day followed by use of an approved topical agent and number of times that you can use that before another scrub. Each of the scrubs is followed by that, and I really think what we've done is you just have to create a culture in your facility that this is how you prepare to go in and see a patient. I'll come back to it has to be convenient. They have to be set up properly. There was a study done, and this is something that I found surgeons buy into. There was a study done comparing OR efficiency and how much time you can save in the course of a day using appropriate hand sanitizing agents in addition to intermittent scrub through the course of the day. And it comes down to something along the lines of one additional case per day in a facility that averages 45 minutes per case. If you do that, so it is actually it's a carrot type of incentive that there are ways to do it that improve efficiency and improve patient safety at the same time.
Thank you, Dr. Miller. We have time for just one more question. This attendee asks, I am unaware of centers tracking the lot number on sutures. This seems impossible to do. Can you comment on that?
Yeah, I can, because we had an issue of soft tissue reactions with a specific type of suture, and we're able to track that back. You at least have to know reasonably well what lots are used. It's hard to do that on a patient-by-patient basis. But what you can do for suture material is track the lot numbers on the boxes so that you at least know within a time frame certain lots were used. And if you run into a consistent issue, and it turned out to have been a processing problem, that there was a bad lot of suture. And the patients all had been done within a time frame, and we could reasonably narrow down on that to address that. This is actually something that occurred, we saw when I was in my residency also, and found out that it had been a processing problem. It actually was a reprocessing problem at a facility, and they tracked it back the same way. So trying to track suture on a patient-by-patient basis is difficult, but looking at least your lots and knowing when lots have been used is something to consider if you have to backtrack to look at superficial infections in patients.
Okay, thank you very much. I want to thank, again, our presenters, Dr. Peck and Dr. Miller, for their excellent presentation, and for all of you who participated today. As a reminder, if you direct your attention to the last slide, if you have questions, you can email the address you see there. And we look forward to having you join us for future webinars. This will conclude today's program, and have a wonderful afternoon. Thank you.
Thank you.